Hi, I'm Dr. Youssef. I'll be presenting to you this case of lamellar developmental cataract, which started. This kid is 6 years old and started to develop a diminution of vision. He's known to have esotropia. In addition, his glasses are +6, and his intraocular lens power was calculated to be 36. So this case will start as usual. You can use a superior incision to be underneath the upper lid, but you can also use the temporal. I'm more comfortable with temporal incision. The same thing, we'll inject here Vitrax into the anterior chamber. And the capsules here are very elastic and tricky, so I'll use Helon 5 to avoid that it runaway rexus. So it's very tricky to do the cataracts. I usually use the stone to open the capsule, but here it's very elastic, so you have to use something that's sharp. So I'll use the cystitome first and then capsulorhexis. Because the capsule is very elastic, you have to be careful with the direction of the pulling. Normally we pull towards the way we want the capsulorhexis to run, but here we pull the capsule or flap 90 degrees to the direction you want it to go to. So that's starting the capsulorhexis here. See, I'm pulling inwards rather than the usual out direction of the capsulorhexis, and you can still see the capsule being pulled inwards because of it's elastic, and at the same time the capsulorhexis is running 90 degrees to the direction of my pulling. I'm pulling inwards toward the center of the lens, and at the same time the capsulorhexis is running 90 degrees to that pulling direction. So this is the most tricky part of the cataract in the developmental cataract, the 6 years old. Of course, implanting the lens here as the standard, we target to be to end up, because he's 6 years old, so we target about +1. There's a curve to where you should target your refraction, because with time they get myopized a little bit. So you calculate the intraocular lens implant to following a curve. It should be a +1 for this age. Hydrosection, not much hydrodelineation. You'll find here that the lamellar cataract actually went out completely out of the capsule, almost outside the lens, including the nucleus. So it went out completely there. So it's mainly irrigation aspiration rather than phaco, but we'll use the phaco probe as usual to manipulate the materials and remove them. Okay. So it's mainly just irrigation aspiration. Use a chopper just to manipulate things out, but there is no hardness to this cataract at all. It's just completely soft cataract. This kind of lamellar cataract is usually congenital, developmental, so it starts after birth, and it's usually bilateral asymmetrical. In this case, we did actually both eyes under general anesthesia at the same time. It's bilateral simultaneous cataract extraction. So we'll use the J cannula to clean the capsule. Here we don't need to do posterior capsulorhexis, as the kid is old enough to sit on the egg later if we need the capsule becomes opacified. The J cannula we'll use here as usual, like we use with the adults. We wash the material, clean capsule, clean cortical material fornix as much as we can, so that we decrease the amount of scarring that kids would get, because the younger the patient, the more active are these cells, and the more chances of getting posterior capsule opacification. So we clean as much as we can. J cannula does a good job doing that. Cleans all the cells and even the fornix where you don't see. We try to target to get about 5 millimeters capsulorhexis. This is about 4.5, so it's a little bit less than what we want. So I refilled the J cannula because it's I used all the 10 cc, but just to make sure that I clean as much as I can the cortical material for the fornix, and to produce a very clear posterior capsule. The use of J cannula here is safer than the IA. It's clean. It does this same job, but much more efficient because it cleans all the minute cells. Here I'm injecting Helon to inflate the capsule, and I'll implant the intraocular lens, which is here ZCB00 plus 34. Again, the calculated intraocular lens was plus 36 or 35.5. So I implanted 34. So just first of all, this is the highest power for this lens, this kind of lens, and I didn't want to implant a lens that has glistenings, because the Acrosoft SN60 AT can go up to plus 40. But again, I don't like the glistenings, the quality of the optics. After a while, it forms vacuoles inside the lens and affects the contrast sensitivity long term and visualization of the fundus. The material of the AMO ZCB00 is better, has a nice optic edge, and it's also aspheric lens wavefront guided. For the aberrations, it decreases the aberrations. We do the same thing. I always try to implant the lenses in a vertical position, so I put the lens to make sure that it's in a vertical position, and I cleaned as much as I can the interior cellular material from the back of the anterior capsule, to make sure to decrease the chances of having the anterior capsular opacification or posterior capsular opacification as much as we can. So went out, did the IA, cleaned up any cortical material. So here we did the J cannula after the the problem with the kids too is that they have low scleral rigidity, so the eye tends to collapse easy. So here I'm hydrating the wounds well. I'm using Avalox here to guard against infections and hydrate and seal the wound. But in kids, we for this age, we usually put an absorbable fine suture like 9 or 10 Vicryl, because we can't remove it later. So here I'm putting the suture. So because the kids, of course, are active, they can rub their eyes and can. So we have to make sure that it's the eye is well sealed. Went really well. We did both both eyes bilateral asymmetrical, because we don't want to put the kid twice to sleep. And the case was done and went really well. Thank you very much for watching.